Leria just joined us. Hudson, do you want to say something about Leria's support for us?
Yeah, let's start. Yeah, let's start. And Dr. Leria, welcome. And I want Leria because it's
I think also lost.
Leria, and we can into this Zoom where form for Leria Fountain is very good and having of
Hello, Hudson. Hello, everyone.
we are.
I'm so happy to see everyone again. Thanks for coming. It's our pleasure to invite with everybody this meeting. Get success to everybody.
Thank you, Dr. Leria. Thank you very much for your support.
Okay.
We're starting now.
Okay, I think that maybe Hudson had a technical problem.
He's paralyzed. Yeah.
Yeah.
Okay.
Yeah, his screen is freezed.
Yeah, okay. So I'll just go ahead and present. And this presentation will start in a few moments. I want to thank all the participants to the second Zoom of Retinawesome, and especially Dr. WAICHING Lam, from who teach Dr. Hudson. He's thanking because he's offline now. In COVID times, we are trying to learn from others' experience and also interact, hoping we can help people build a better future by relating to each other and donating love and care. So our panel will start with Dr. WAICHING Lam from Hong Kong. Dr. Lam, do you want to share your screen?
Sure. And just 1 second.
And actually, I have video from
So this is a case of management of macular fold. This 50-year-old gentleman presented with symptoms of flashes and floater and past histories of cataract surgery about 3 months ago in the right eye. And he basically has a superior macular on retinal detachment with a giant tear, but there wasn't that much subretinal fluid. And there's only about a couple of this diameter fluid. And so he underwent the routine kind of approach with vitrectomy, laser, and gas injections, 20% SF6. And this is the post-op pictures of the superior retinal giant tear, and with the laser burn, and the retina is all basically reattached. Unfortunately, he developed a fold over to the macula. You can see that very well. And that was a surprise because the macula was previously on pre-op. So that was also disappointing to see that. After waited for a while, and here's the OCT showing the retinal fold near the macula. After the wait a while, we decided to proceed with the surgery to fix it, and he underwent vitrectomy. I'm going to go to the video instead. Just 1 second.
You want me to display the video or you?
I should be okay.
Okay, okay, that's fine. my connection was lost for a while. Now I have the cell phone as well.
Okay. So, so we decided to do a vitrectomy for the case, and using a 39 gauge subretinal cannula, a localized retinal detachment was created around the retinal fold, and then using the airflow exchange to allow those two large blebs of subretinal fluid to coalesce. And because we waited a few weeks, there was already some stiffness of the fold. So using the diamond dusted membrane scraper was helping to undo the fold. And then the PFCL was injected to flatten the detachment and to displace the subretinal fluid. And just additional manipulations to flatten the fold. And then a small retinotomy was created temporarily to drain the fluid. And then the retinal break was laser. And back to the PowerPoint. So here is the postoperative pictures showing the undoing of the fold. Although there's a little bit of cystoid macular edema, the vision was 2200. And here's the fluorescein angiogram showing the retinal fold undone with a little bit of residual intraretinal fluid from the mild cystoid macular edema. So the point about the macular fold was not new, and it's been reported way back in 1984. And it is an uncommon condition, but it does happen. It happened up to about 2.8% in one of the study. It's thought to be from the fluid, particularly a superior retinal breaks, that gravity draws them and they track towards them inferior retina, and if it happens to be the macula, then it become symptomatic. If it's extramacular or outside the arcade, they probably can be left alone. And the risk factor was thought to be superior bolus retinal detachment, a circumferential buccal where you create retinal folds, and that also be a risk factor for the macular retinal fold development or macular fold development and slippage from the giant retinal tear. And what's interesting I found is that in animal study looking at the retinal fold, within 1 week having the retinal fold, you actually start to see some losses of photoreceptors and changes in the outer segments. And by 4 weeks, there are actually permanent damages to the photoreceptors. So the idea for waiting for the to see if the retinal fold undo can actually means that that can cause some irreversible changes. And for my case, I actually waited, I think, a little too long. I waited almost a month before I decided to take the patient back for more surgery. So the way to prevent it is to make sure that the patient do face down immediate post-op for any superior retinal break of retinal detachment, and that will minimize the risk of this gravity pulling the fluid towards the macula, and allowing that to usually just the first couple of days be sufficient to minimize these complications. And that's it. So welcome for the discussions of the management of macular fold.
Yeah. Dr. Gustavo Honey, do you want to comment something about this case?
Hello, can you listen to me?
Yeah, perfectly.
First of all, congratulations for the surgery. These cases are really tough. So far in my career, I had just one, and I wanted to know if you already faced anyone who you couldn't solve the fault.
I guess if you leave the fold for too long, if you get subretinal fibrosis developed, and the fold may not be easily unfold. But I think if you get them done within the first couple of months, they should be able to be undone, especially the technique I use is not unique. A lot of people use the same methods to create detachment, basically to undo the fold. The use of the heavy fluid helps to flatten the detachment completely and reduce the risk of the fold being recurrent. And so I think if you don't leave it in for too long, it definitely should get undone.
Thank you.
Dr. Martinez, do you want to comment something about this case? Do you have a comment?
What we do for slippage, to prevent the slippage, is that we use fibrin glue.
No.
We use both of the different cannulas, so it does not make a clot when you use just one cannula. And under air, with the perfluorocarbon nearby to the border of the detachment, what we do is we put the fibrin glue, and that helps us for at least 15 days. That to prevent the slippage of the retina is really interesting. Who is now doing a protocol regarding this is, I think, Mario Sarabia in Argentina, but we have been doing this for a couple of years now with good results.
Very good, yeah. I remember you mentioned that last time about using the glue to manage giant tears to prevent slippage, yeah.
I like the glue. I don't like to make sutures. So I'm lazy for suturing. So I like the glue.
YOSHIHIRO, there's a question in the chat asking, in the first surgery, was the PFCL used for the giant retinal tear?
No, it wasn't done. There's no need for it because the amount of subretinal fluid wasn't that great, wasn't that much. So I didn't feel there's a need. And it was a MAC-on detachment, and I didn't expect the fluid would track that far progressively because the subretinal fluid was outside the equator. And so I was, I guess, too relaxed about the concern of the potential of macular fold development. Since then, I keep everybody face down after surgery. It doesn't matter the extent of the tear or the extent of the residual subretinal fluid. The truth, though, is that you never can completely remove all the subretinal fluid from the break with air fluid exchange. There's always some fluid either accumulate or remain there. So that means the potential risk of the fluid track towards the macula is always there. So I think it's a good practice to make sure the patient face down for at least the first night to allow sufficient reabsorptions of the fluid so that to minimize the risk.
Good, I think excellent surgery, YOSHIHIRO, and I think that's what same thing I do. I don't use glue, but I do the retinotomy, and there, in case some places, I think recently I do a ILM peeling when the fold is across the macula.
Great.
Thank you very much, Dr. WAICHING. Shall we continue, Dr. Hudson?
Yeah, Dr. Lam, do you have another case?
No, just one case.
Oh, that's fine. Okay. Very good. I just wanted to comment on the needle sometimes we use to drain the subretinal fluid. What the gauge is? 38?
I use a 39 subretinal cannula to create a detachment. For the drainage, I just use the case was done with I think 23 gauge. So just the 23 gauge cannula to drain. There wasn't any need to use any specialized drainage cannula.
Okay, thanks.
Okay, thank you very much, Dr. WAICHING.
Thank you.
And now Dr. Maria Martinez Castellanos from Mexico have a case for us. We're looking forward for you.
So what I will be talking now is, I am a pediatric retina surgeon, but sometimes it's more interesting talking about adult retina than pediatric retina for most of the audience. So what I'll be talking about is something that is recently found, and we took the time to make a classification about this. I'm trying to make it short in just 3 minutes. So let's see if we can make it. This is a case of a woman that is myopic, and she was born at 32 weeks. This is the eye. And as we can see here, we have a lattice degeneration. We have an old demarcation line, and we have these scars that we have seen them in patients that we treat with anti-angiogenic therapy, and then the vessels of the retina growth towards the periphery. So what we performed was a buccal vitrectomy, and we use silicone oil. And this is the result after surgery. We perform an angiogram. This surgery was by one of my fellows, but we saw that there is a vascular areas in the periphery. So we know now that these avascular areas are also in adults that were premature babies. This is a 15-year-old teenager. This is pre-anti-angiogenics. So this retina is not well developed. And we have a different features that will have a retinal detachment in patients that had the history of being premature, like the traction of the macula with the retinal cases just because of traction. Here we have to perform a vitrectomy and remove the posterior hyaloid. I prefer to use a peristaltic bone to do that. We have exudative retinal detachment with fat deposits similar to Coats, but is not Coats disease. This is for ROP. And they may have also these vascular tumors like little hemangiomas in the periphery. We have to perform an external drainage, if possible, to not touch that vitreous, if possible. So you have to perform the external drainage, sometimes a buccal, and in laser in the periphery, or cryo if we have the tumor in the periphery, and that it may require a second or a third surgery. This funnel-like is very, very particular in patients that had ROP. The macula has this funnel-like detachment, and the ion detachment from the limit of the cryo or laser in babies that were treated. These are really difficult to treat because they are very posterior. They have a really abnormal scar with the vitreous. And here we don't know if we have to buccal or not to buccal because of the posteriorness of the break. The lattice association breaks in non-perfused retina. This is an avascular retina with little holes like the ones in the patient I presented at the beginning. And we have to have in mind that this vitreous is completely different to the vitreous of just a retinal detachment in an adult. The membranes could be very, very anterior. There is an adherence on the old demarcation line of the vitreous. Maybe there are no visible breaks, and we may have a vascular retina. So ROP is a lifetime disease. Even if they don't develop ROP that require treatment as babies, they may have sequels of ROP. And I think that every patient that has a retinal detachment, one of the questions that should be asked in the history is if the patient had ROP at one point or was a premature baby, because these detachments are completely different to what we see in other kind of detachments. Thank you. I'm open for questions now.
Very good, Maria. I think you can hear me?
Yes, perfect.
Yeah. My excellent case, but how many years like an ROP baby can have detachment? Like you said, this child was 15 years old.
Yes, for example, my coworker, Jerry Garcia, he's with me in the hospital. He has a lady that developed a new vessel with vitreous hemorrhage at the age of 78, and she was premature. 78 years old, and she was premature. So this is a lifetime disease. Retinopathy of prematurity can give you problems in the eye for a lifetime, problems in the retina. The vascularity is not normal. The vitreous is abnormal. The development of the eye is abnormal. So we have to screen these patients for a lifetime. And when we see retinal detachments, sometimes we see these retinal detachments that are different, like weird, that is not it's not myopic, but the vitreous is complete. And when you ask the patient that you ask him, were you premature? And they say, yes, I fitted in a little box of shoes, or they at the end, they tell you that they were born before time. So we have to screen this in babies.
So do you do yearly screening?
Yearly screening and screening later every year at least.
Okay. But what do you do to prevent it? Like, for example, you do every year screening. How do you prevent detachment?
You can't prevent detachments unless you see little holes in the periphery or a vascular retina, or in the angiogram you can see new vessels, pathological new vessels developing afterwards, especially in diabetics, for example, that they will have vascular problems. So you have to be careful with these kind of patients. If you see an abnormal vitreous, that if they have a posterior detachment of the vitreous, they may develop tears because this scar between the demarcation line, the old demarcation line, this scar that can make you a hole or a big tear in a posterior detachment just because of age.
Very good surgery, Maria.
Yeah, Maria, there's beautiful presentations. I have a question. Will you approach this group of patients differently surgically? Because they usually will present with combinations of rheumatogenic and tractional types of detachments. Like any surgical tips and techniques that you will do different than the usual adult detachment?
We perform a lot of buccals in these patients. We prefer buccals with vitrectomy, not just the buccal, but we perform a lot of buccals now that the tendency is to use less buccals in retinal detachments. I think that these cases are the ideal cases to use a buccal, because the traction is abnormal. So if you release a little bit of the traction and you remove the vitreous, you have better chances to have a success after the surgery.
And I see that you do, sorry, I see that you
sorry,
so I saw that you use external drainage and for using the sclerotomy to drain the subretinal fluid. Is that your preferred method rather than internal drainage?
No, for the exudative, the ones that is only exudations that you can't find the hole, and that in some of those cases, they have a vascular tumor like an hemangioma in the periphery. In those, I prefer to do external drainage and not touching the vitreous in those cases. In the ones with the rheumatogenic detachment, I do internal drainage as everybody else.
Thank you.
Thank you, Dr. Martinez. I would like to ask Dr. Vasco Bravo if, Dr. Vasco, do you want to comment on the surgery?
Yeah, first of all, congratulations, Martinez, for the very difficult and hard case. ROP cases are very challenging. I don't have experience with those kind of surgery, but I'd like to ask you if, for some reason, that patient that you showed that was submitted to anti-VEGF therapy, does the vitreous has a worse adherence than the usual young patient has, or is like a regular young patient? And I'd also to ask you about what is your approach on those ROP patients when they are older and you find lattice degeneration or other type of degeneration, about laser photocoagulation? Is the same approach as a regular adult, only when you have symptoms of retinal detachment history, or you have a more aggressive approach doing prophylactic laser photocoagulation?
I do not do 360 degrees laser. I prefer just to treat the single lesion if I can see the hole. But
every lesion that you see in a ROP patient that as an adult has a lattice degeneration, for example, you do laser?
I laser.
Okay.
I laser. I laser that area, but I try not to do very white scars. I prefer to do like a milder laser. And there is also a chance to do cryotherapy.
Okay.
Because this avascular retina may develop also an abnormal tear around the laser scars. It's also, that may happen also in patients that were treated for holes in the retina, and then they develop these retinal detachments, the bad ones. And some of them, if you ask them, they are premature. They have this abnormal adherence of the vitreous with the retina. So I believe that all these patients with a retinal detachment, one of the questions that is a key question is to ask if they were premature babies.
Perfect. And about those patients that were submitted to anti-VEGF therapy, and do they have a more adherent vitreous?
We don't have really until today a rhegmatogenous retinal detachment due to in patients that were treated with anti-angiogenic therapy for ROP in what we have seen.
Okay.
Except the ones that they had the needle in 3 millimeters from the limbus, and they have a iatrogenic hole. But we have not seen retinal detachments in patients like rhegmatogenous retinal detachments. We do have seen the ones of a tractional retinal detachment if the anti-VEGF is injected late and there is already a detachment. There is already abnormal vitreous.
Great, thank you. Congratulations.
Thank you.
Thank you very much, Dr. Castellanos. We are going for the next video with Dr. Vasco Bravo. He's from Brazil, and he will be presenting now. Can you share your screen, Vasco?
Yeah. Can you share the screen, Vasco? You want me to do that?
Can you see my screen?
Yeah, sure.
Yeah. That's
perfect. So first of all, Hudson, thank you very much for the invitation. It's a great pleasure to be with all you guys with such expert team tonight here in Brazil. And I'm going to show you a case of that was sent to me. It's a recurrent retinal detachment with a macular hole. I first saw the patient, and then I decided to perform the vitreous-based review because I had some vitreous yet. So when I realized it with the PFC, I saw the macular hole that was not seen before. So I removed the macular hole, the PFC, and used the brilliant blue. I want to show how the peeling without the PFC, it's harder. So now I use the PFC, and the ILM peeling under PFC, in my opinion, is easier than without the PFC because you have the retina attached. And so when you pull the ILM, I think it's easier to come than when you perform the ILM peeling without the PFC. So every time that I have macular hole, even in a primary retinal detachment, I always do this type of approach using the PFC to remove the ILM. And then, as was a recurrent, ILM had some PVRs that I didn't show in the video due to the time. We did some laser of some new tears and left with silicone oil. So,
thank you very much, Vasco. Beautiful surgery. Dr. David CHOW, do you want to comment on this technique?
Yeah, sure. Macular hole detachments are typically from trauma or high myopia. So I'm presuming this patient was quite myopic, very myopic.
Yeah, it was about like -7, -8.
Yeah, and on the OCT, was there much of a staphyloma or no, not really?
No, there was not.
So, I think the technique you showed is a very traditional technique. And I did that for many, many years. And I think over the years, I know since we've altered our approach to ILM management over the last 3 to 5 years, specifically, we see flaps and inverted ILM flaps and stuffing all kinds of stuff everywhere. I think, the myopic macular hole detachments, there's been a couple papers in the last 2 years that show if you kind of fold the ILM and then stuff it into the hole, you've got a better chance of not only getting rid of the retinal detachment, but also closing the holes. And I was never one that was a big fan of stuffing the ILM into the hole and kind of just stuffing all the tissue down there. I thought that the ILM would actually prevent the hole from closing. But I think the studies that have been coming out have been becoming more and more convincing that, at least for macular hole detachments, that kind of inverting the ILM tissue, and there's a whole bunch of different techniques to do this, you know, like petaloids, and then rolling it in, rolling it in, rolling it. There's all kinds of different descriptions on what everybody's trying to do in the same manner. I've kind of altered my approach to do something along those lines. So I don't have enough cases to present a lot of data on it, but I do think that the literature is pushing in that direction.
Yeah, I think nowadays is a very trend, like you fill up the hole with something. I agree with you that maybe in myopic patients it's maybe one day we have like real strong data showing that. I don't perform as first option. This patient didn't have a macular hole before in the first surgery. So because of that, I decided to do this type of approach. Usually other macular holes, not with retinal detachment. I don't perform as a primary surgery the filling with anything. And I don't think it's the best approach for now, but I agree with you. Yeah, I think maybe I didn't change yet, but next time I'm gonna remember you and try to fill up, in this case, with my high myopic patients with the ILM.
The one who did a really nice review on this was Dr. Terasaki. She did a very nice review on the literature of macular holes through the spectrum of myopia. And once you got through to the macular hole detachments, I remember her showing very elegantly 3-4 studies in the last couple of years where that data played out. And I was a little surprised myself. So that's why I kind of altered my approach a little.
Yeah.
Thank you. Dr. Sasamoto, would you like to comment on this?
Yes, sure. My question is, what about a failed surgery? I mean, you do the ILM peeling, but you got a patient with a new retinal detachment, and what's your next step? That's my question.
If I had a patient like that I removed all the ILM, I have access to amniotic membrane, so try to use the amniotic membrane. But I think that sometimes it's hard to have amniotic membrane. I think a good approach is you perform the posterior detachment with a 38 gauge needle. And so you do the subretinal fluid and you try to, with the tunnel, you try to do some massage to put it down back and to see if you can have the macular hole back and the retina back. But I think I would do first, if I have access to the amniotic membrane. I think amniotic membrane, it's a little it's quite difficult technique. I think the subretinal detachment, subretinal fluid detachment with a 38 needle gauge is easier to perform on those cases that you have refractory epiretinal macular hole and you don't have any internal limitant membrane to perform, to use it.
Okay, but let's say that this amniotic membrane failed also. Did you consider, or do you consider use laser?
Use laser?
Yes. I mean, the third or the fourth patient, or you got a patient with a failed surgery and still the retinal detachment. How can you, and the only problem is the macular hole. So my question is, if there's a failed procedure third time, what do you do?
After we pray to get everything goes well. I never had a case like this, thanks God. But I think a next approach, if you do this, you put amniotic membrane and off, I think the only option is use a retinal graft or RP graft, you know, go to the periphery, try to have a big area of RP retinal transplantation to try to help this macular hole close and avoid this retinal detachment due to the macular hole.
Okay, and this patient is like a 20 diameters, myopic. So the thing that I'm asking because we got a lot of patients with that colleagues used to put laser here in my city. I mean, it's an awful procedure, but it's a reality. So there are some patients with 20 diopters or 15 diopters. There's a povascusis and there's a chronic problem. So I'm asking because of that. It's a real situation.
Okay.
Thank you very much, Vasco.
And
now, oh, sorry,
Sure.
Dr. Natarajan, do you want to comment?
I think I had a patient like this, and like third surgery, I decided and used Denziron as a heavy oil, and then removed the oil, and the retina and the macula hole remained closed.
Okay.
Yeah,
Thank
good.
you.
Thank you.
I'm gonna show Dr. Yonekawa. You're ready?
Okay.
I'm gonna
you have my
share.
video, or should I do screen share?
Yeah. Do you want me to share or you share?
Either way.
Okay.
And
Okay. So I'll share the screen.
okay.
Just a second here.
Thanks very much for having me, by the way. And my name is Yoshi from Philadelphia. I'm at Wills Eye Hospital. And we don't have to play. I'm just going to, a few things about this case. This is a 4-year-old boy who, maybe you can pause it. I wonder if it's better if I share it. The video is very choppy.
Okay.
And so the mainstay for Coates disease would be laser retinopexy. So you have to ablate the abnormal vasculature, the aneurysms, and to decrease the exudation.
You want to share?
Yep. And but when you have larger detachments that are exudative, it's more of a therapeutic challenge. And over here, and so if the exudation is, if it's a partial detachment, I think it's reasonable just to laser the vascular changes. Not even cryotherapy these days. You can do continuous laser, ablate the vasculature that's leaking, and the retinal detachment will fix itself. And if it's a total detachment like this, I think my go-to technique initially was external drainage only. But if it's really severe with the retinal detachment right up against the lens, and for this patient, the lens iris diaphragm was pushed forward and it was very close to the cornea too. These eyes don't do really well and they keep on recurring. So I went very extreme in this case. And one of the first tenets of pediatric retina surgery for tractional or exudative detachments is not to make any iatrogenic retinal breaks. And so we're going to fix this without doing that, and we're going to use an external drainage approach, but we do a little bit more. And so I'm playing the video now, and we do a peritomy here, and we're injecting Helon there to inflate the anterior chamber so that we have surgical space. And I'm inserting the trocar into the anterior chamber here as an AC maintainer, basically, because we don't want to go into the pars plana because retina is right there. And so the trocar goes in here. That's a technique taught to us by Tony Capone. And this patient, I sent the subretinal fluid to pathology because there was a mass on the B scan where some people were a little concerned about possible retinal blastoma. This is, the fluorescein showed that this was Coates disease, but just in case. And so as we do that, the subretinal fluid comes out, and we're going to express the fluid, the posterior fluid out as much as possible, but I'm seeing that the retina is still not attached well enough. And so I decided to go in the eye. Usually you don't want to do this for Coates disease, but I felt this case was very severe. And this is the key step where we have to make sure that the pars plana is now available. And so we're pressing really well, making sure that the pars is available. And we're making sclerotomies here without cannulas because there's not too much space. And so we're going old school, making direct sclerotomies into the sclera. And in these cases, there's really no real vitreous. Everything was so compressed. And we're injecting PFO here to push the fluid out through the external sclerotomy. And so we're able to drain this excess fluid without making any breaks in the retina. And this was first described by Shunji Kusaka, and it works really well. So now that the retina is attached, we can really treat the lesions very well with retinopexy. And we're using silicone oil here for a number of reasons, but this patient did really well and maintained hand motion / light perception vision for 1.5 years after follow-up. And so far, so good. Okay. And previously reported surgeries of this type, usually a lensectomy is performed, but I think if you inspect the pars plana really well and you're careful about making the incisions, you can do lens sparing, which is kind of nice because these kids don't position very well, and that's likely to cause pupillary block glaucoma.
Excellent surgery, Yoshi. And I read an article where we don't do a vitrectomy at this stage. So I have about 4 cases where I do same as the AC maintainer to maintain the intraocular pressure and make a sclerotomy in the earlier open the conjunctiva, tag the muscle and do a posterior sclerotomy where the bullets are deep. And then you drain it and probably you can inject the air in the vitreous cavity and also use the anti-VEGF and do a peripheral cryo for the telangiectasis vessels.
Mm-hmm.
And I think it worked well. And nowadays I don't open the conjunctiva. Next 3 cases, I just do a transconjunctival transscleral using the viscofluid extractor. I do the infusion line and use the indirect ophthalmoscope to see whether you are not damaging the retina and use the viscous fluid extractor. I think it has worked well in 4 of my cases.
Okay, very nice. Yeah, that used to be my go-to technique also. I just felt this case was a little too severe. And the other problem was that follow-up I knew the follow-up was not going to be too great. And I feel like these Coates patients, you have to keep on treating them every couple of months for the exudation to go away. So I want to do something very definitive.
Yeah, very good case.
Thank you. It was beautiful one. Dr. WAICHING.
Yeah, I just want to ask a question. Yeah, beautiful surgery. That's also my technique. But for external drainage with an infusions, what was the reason why you think you didn't have a complete drainage? Because was the locations of the drain site? Because sometimes we have a tendency to put the sclerotomy very anteriorly, and when you have quite a bit of fluid posteriorly, it may not be able to migrate forward. And sometimes the cholesterol crystal actually blocks the drain site, and that also can limit the amount of drainage.
Yes.
And so in your situation, what do you think could be the reason why it wasn't that adequately drained?
Yeah, that's a great point. What I didn't show in the video was that I made other sclerotomies also
okay.
that were more posterior as well, a bunch of them, and there was still all that fluid. And I was ready to just, stop the case and then, call it a day and come back to it, which I think is totally fine as well. But I just went the extra mile here.
Right. Yeah, I too will do another drainage site if it didn't drain well. But since you have tried, just wondering the reason for it. Maybe something just blocking it. I don't know.
Yeah.
Good surgery.
Thank you.
So Yoshi, I was going to say the goal of achieving a more thorough drainage is so that you can better ablate the leaking vessels with cryo?
Yes. Yep.
Gotcha. And so I get that mindset totally. I don't think I saw it on the video, but it was a 4-year-old?
It was a 4-year-old, yeah.
So that's a hard vitreous to remove and then fill up the whole eye with perfluorocarbon.
Well, actually, I just showed you like 2 seconds of the vitrectomy, but in these cases where the retina is up against the lens, the vitreous is really super compressed and there's nothing there. And so I went in there with the cutter, but there was nothing there really. And this is often the case.
So you think the vitreous is all just compressed anteriorly with a PDD? Or is vitreous thesis and the hyaloid is split?
I think the hyaloid is still down, but everything has been compressed. And so because some of these cases, after you follow them for many months, you can still have like this posterior hyaloidal contraction.
Right.
So you get tractional elements to this also, which is only possible if you have hyaloid in there. But when you're in there, you know, the PFO went in beautifully, no problems at all.
And that I was surprised about, because I was watching it thinking it's going to be hard to get a really good vitrectomy, and then you filled up with perfluoron and it looked beautiful. But you and I both know that if there's a lot of vitreous in an eye and you fill it up with perfluoron, sometimes it doesn't always behave so elegantly for you.
Yeah, I agree. I think with the total detachment like this, the exuded detachment in coats particular, there usually no vitreous left when you collapse the detachment. And they might have a lot of subretinal fibrosis and some pre-retinal fibrosis, but vitreous, they are all gone or compressed.
I wish it was like that for all of the pediatric cases we do.
So it's a beautiful surgery, Yoshi. I really enjoyed.
Thank you.
It's important to tell there are some fellows or residents that may be there. And even if you see these retinal detachments, that is a complete retinal detachments, that you don't know if the child has any sight, any light perception or whatever, it's important to perform the surgery, because sometimes they improve some vision, and you can delay a neovascular glaucoma or other complications for a blind eye. So it's a beautiful surgery, and I think it should be performed whether if there is a sight future in that eye or not, but it's better to perform it before we have complications. I don't know what you think about.
I agree. The visual prognosis, admittedly, is not great. I mean, I'm very happy with the light perception vision he's going to have. So I think setting expectations is very important when talking to the family. Coats disease is more common in boys, and boys, you know, what we do is we do stupid things. We bump into things, we fight each other, and so boys are getting hurt all the time. And so that eye that we fixed may end up being his better eye for all we know. And so I think that's another reason too. Being male is an independent risk factor for ocular trauma, I think.
Yeah.
Perfect. Thank you very much for the questions. And Dr. ANDRÉ JUCÁ, do you want to comment on this one?
A very nice case. Congratulations. Where do you think the fluid came out? Because there was no hole on the retina to drain the fluid. Do you think it came out finally by the posterior sclerotomy, the many posterior sclerotomy that you did?
Yes, exactly. So the goal is to fix these detachments without making a retinotomy. And so the fluid gets pushed out through the sclerotomies.
Okay.
Okay, thank you very much. Now we're proceeding with Dr. David Cho from Canada. Do you want to share a screen, Dr. David?
Sure.
Or Hudson?
I think I have there we go.
Okay.
You got it?
Yeah, perfect for us.
Perfect. All right, I'm going to show you one quick case with a little publication we made out of it, and then a second video on my new favorite cutter. So the first is a macular hole. It's a high myopic male, 76, previous cataract surgery, vision dropped for about a month, and he's down to about 20/80 vision with the macular hole. So I think all of us can argue about what our current macular hole technique is for a small to medium-sized hole. But this guy ended up having what was at the time a very traditional surgery, vitrectomy. We use ICG up here. This had a full typical ILM removal, 2 disc diameters in size probably, with 20% SF6 and then 5 days of prone positioning because he was a high myope. And 1 month post-op, basically the hole's closed, the vision's improving. All right, he comes back now 1 year post-op, hole's closed, the vision's up to 20/50. And now comes back 18 months post-op with no interventions in the last 6 months. And the vision drops back down again to 27. So he's got a recurrent macular hole here, but it's pretty small. So I'm just curious what some of you guys would do here, and then I'll tell you what I ended up doing. Wai-Ching, what would you do here?
Taking back for another surgery, and the hole is quite small. Maybe just another gastric exchange may be sufficient to allow the hole to close. But if you feel not adequate, maybe take a fee flap of IOM elsewhere and put it over the hole, and that sometimes also work for recurrent holes. Yeah.
Yoshi?
Yes, so my go-to technique for recurrent holes or persistent holes would be submacular BSS to lift up the macula and extend the IOM peeling, and then kind of massaging the foveal edges. But here, this case is really interesting because you have a lot of edema here, and I'm wondering that if you treat the edema, if the hole may close. I know, some people talk about this. I think, David, you like that, but there's a lot of edema here.
So that's what we did. We treated the edema. So we went on to Predfort and Ketorolac drops. Came back a month later, the hole's gone. Vision came back up to 20/50 and stayed closed. So we published this last year in AJO case reports and with Gerardo. And this was at the time, it was the second case of a recurrent macular hole treated successfully with steroids and non-steroidal drops. These were the only two cases in the literature we found when we published ours. This was a patient, same kind of story, recurrent. Actually, this one was no previous vitrectomy. So this is primary surgery and had Ketorolac drops done solely. And you can see there the effect of the drops closing the hole. And then when they discontinued the Ketorolac drops, 8 weeks later, the hole came back. And then they put the patient back on the Ketorolac drops and it closed them off again. So that was an interesting case. And here's another one, a month after cataract surgery, gets a pretty big hole, a lot of kind of elevation on those two edges. This one they did Durezol Nevenec and posterior subtenon's Kenalog, and basically that kind of closed off the bridge and flattened off that hole. And then interestingly, just a couple months ago, I found this, and I think this is now published, but this was in press at the time. And this was a series of 123 holes, of which 12 were secondary macular holes, and 9 got treated with topical drops. And they had a fairly decent success rate of 8 out of 9 holes closing for a small secondary hole. So it's just another option. As Yoshi said, he saw a lot of edema. And I think if you see a picture like that, and it's a small, tiny hole, and it's a recurrent hole, I think it's a very legitimate option now to try for a month or two to see whether it will close the hole. Any comments on that? Anybody else, any experience with that?
Yes, can I make a comment, please?
Yeah.
Yes, I usually use also Nepafenac. It's an excellent anti-inflammatory, and I got some troubles with this chronic macular edema, and the resolution only used in anti-inflammatory is quite good.
All right, so I think that's a kind of a cute little case report. The second is the bevel tip cutters. So, you guys know I talk on instrumentation all the time, and like to me, it's like 15 years I've been giving talks on instrumentation, and it's gotten to a point where a lot of instruments I try, it's like, yeah, it's just a small iteration. But I think this bevel tip vitrectomy probe is a big deal. This is one of these kind of aha moments. And, I think even internally at Alcon, they're like, why did it take us so long to figure out how to make this thing? Because it really is a huge difference. So this is a looping video here, where you can see here, like traditionally for complicated diabetics, I had a bimanual technique with a forceps and a cutter. And I did a paper many years ago on something called segmentation stock chop. And these maneuvers I'm doing now with this bevel tip, I would never have had the confidence to do with previous vitrectomy probes that didn't have a beveled port. So that this beveled port getting 40, 50, 60% close to the retina, depending on the gauge, it's really it does change our ability to access tissue planes. So you can kind of feed the tip into the tissue plane, and it will act like a shovel. It will kind of push the tissue up into the port, and because the port's closer to the tip, it really just kind of shovels the tissue up into the port where you can then cut it and remove it. So I am very, very impressed with the beveled port in terms of it being able to change what I can do. You know, not only is it closer and feeds it, but there's also work they're doing, and a couple guys are working on this set of data to show the improved fluidics that come up through that cutter as a result of the change in the direction of the flow through a beveled tip. You know, and this is a question I asked last year at a instrument panel I did at Retinal World Congress, and was just trying to get a gauge on where surgeons felt they were with their opinions on high-speed vitrectomy. And you can see, interestingly here, on those 4 choices that I gave them, there was no question that the surgeons were much more excited about the concept of a beveled probe getting into tighter tissue planes than they were about a hypersonic vitrectomy probe, or they were about going 20,000 cuts per minute or quicker. So I think, you know, to me, this has been a bit of a game changer for the tough cases, not the easy cases, but the real tough cases. Any of you guys had a chance to use this?
Yeah, I use it all the time. It's really wonderful. And David, I'm wondering, so there was a strong push for 27 gauge instrumentation to do these kind of maneuvers, sneaking into tighter spaces. But now with the bevel tip 25 gauge and 23, do you feel, you know, all those benefits that we were getting from the 27, it's kind of, you know, negated now, and we have stiffer instruments that can do similar maneuvers?
Yeah. So I think the sweet spot is probably going to be 25 gauge with a beveled probe. Now, those of you who find 25 gauge too slow, then you're going to want to do the beveled probe in hypervit, the 20K cutter, because the fluidics on that are so much quicker and there's so much more flow there that you're not going to be impatient. And then you can also argue that the hypervit probes, and you know, and this is that we're talking just about Alcon, but B&L has a bi-blade probe, and Dork, of course, were the ones who started this whole thing, all right, with the TDC cutter. So every company now has a version of a twin duty cycle or twin cutting action probe. And I think the value of all of those probes that have such a high duty cycle and such a high flow rate is not only do they address these slower flow rates to do a core vitrectomy in 27, where it is really an issue, but also in 25 for some surgeons, but they also smooth out the flow. And so I know Kirk Packo for many years was always very upset with the notion that the cutting action would create acceleration and deceleration of vitreous at the cutting port. And he did all these nice high-speed videos with particles with Alcon in their labs, and basically showed the concept of the acceleration and deceleration of vitreous bumping into the inner sleeve creates traction. And so I do think also that the kind of the smooth, consistent flow that you'll see with a TDC or, you know, hypervit will result in less of a tractional phenomenon. So I think if you're asking me, that's a long answer to say, essentially, to me, I think the sweet spot's going to end up being 25 gauge, a bevel for all the reasons I said, and then hypervit if you like the idea of smoothing out your acceleration and having a very high flow rate capability. The 27 gauge flexibility issue you brought up, you know, every year at Fellow Forum, I ask everybody to rank their attitude towards the issues with each gauge. And for every year, it's always the same. 27 gauge, nobody likes the flexibility. It's such a problem. And so I do think there are a lot of different material things coming down. So I think the big players are looking at a number of coatings, a number of different ways they can stiffen up a 27 gauge probe. And then some of the smaller guys in the marketplaces like Catalyst, they have a stiffening, a retractable little stiffening sleeve that is surprisingly effective. So there are a number of different ways you can try and address the flexibility issues in 27 gauge right now. But for most people, it doesn't matter what you give them. It doesn't matter whether you tell them it's stiff or they still end up saying it's too flexible 27. And actually the world usage of 27 right now, in North America, it's under 3%. So we talk a lot about 27 gauge right now, but there's only 3% of cases being done in North America in 27 gauge right now.
For those who, I mean, we don't have Alcon in my country, so we use Oertli, and there's a platform called Speed Pump. It's a hybrid between the peristaltic and the venturi pump. So I usually perform those type of surgery, removing membranes with that type of pump, and then I have a good results. Just a comment.
So that's a little bit, I think the Oertli went down the flow-based vitrectomy pathway, you know, and I think Didier Decorno used to be a very, very big advocate of that, of this kind of flow-based vitrectomy, right? Constant flow. It's a little bit kind of the same concept we're getting at when you start to smooth out the flow patterns with a hypervit where the duty cycle is so high, all right? So, but yeah, most of us in North America have never seen an Oertli machine, right? They're just pretty much, I think there's 0 accounts of Oertli in North America.
Dr. Shaw, question from the audience. Is there any illuminated vitrectomy probe on the market or something coming?
No, there is not. It's been talked about for 15 years. You know, the question with all illuminated probes is that you have to put the fiber somewhere pretty close to the working port of the instrument you're trying to use. So illuminated laser probes, illuminated forceps, illuminated scissors existed at one point, not anymore. So all of those suffered from a problem that when you put a little light fiber on the edge of the instrument and you got it down close to the working part of the instrument, the cone of illumination created by that fiber being so close to the working site was very small. So it ended up creating this kind of poor illumination pattern, and you really struggled trying to come up with a wide angle fiber that was able to kind of spread the light out far enough that people could use that instrument as an illuminated instrument and be happy with it. And it was the same issue for the cutter. So I think what you could do, you know, and the way to kind of move forward if someone was really serious about it is to do a 27 gauge cutter in a 25 gauge port and then throw a fiber in there. And then again, the arguments are always, where does the fiber exit the probe and what new fiber can you create to spread the light in a manner that's going to give you a nice pattern of to work in.
Thank you very much.
I have a very quick question to Dr. CHOW. Sorry, CHOW, how long would you wait for the macular hole treatment, edema, to see any answer about closing the hole, like 30 days, 6 weeks?
I would wait 6 weeks, but I'm not sure I'm right about that. I don't know whether if you waited 3 months, you know, you might see some more of these holes closed. But I think 6 weeks to me at least is long enough to say you gave it a legitimate chance to work. And if it didn't close, then you did everything you could to keep that patient out of the OR.
Great, thank you.
Thank you. Now we'll proceed with Marcelo Murillo Sasamoto's video.
Yeah, I'll share Dr. Sasamoto's video here. Just a second. Yeah, we'll start. Marcelo Murillo Sasamoto, this is the case.
We are not, okay. I'm just putting it. Your mic is off, Marcelo.
Okay. So this patient was referred for vitreoretinal management. Can you put a full screen, please?
Sure. That's it.
It's VASCO.
No, it's not that.
Sorry about that.
That's okay. You want me to play here, from here?
Yeah, sure. I don't know what happened. It's kind of blocked.
Okay.
Okay.
Can you see the presentation?
Yeah, perfect for us.
Okay, so I was saying that this patient was referred for vitreoretinal management, a 90-year-old male, victim of assault with blunt trauma. The visual acuity was count fingers, 50 centimeters. That was the refraction. That was the left eye with the injury. As you can see, there's a myopic patient with a high astigmatism. So this we can see in the angiography rupture, a choroidal rupture, a traumatic choroidal rupture with a fibrocellular epithelial membrane, epiretinal membrane formation. So we can see also this striated appearance of the neuroretina. Also, the patient had this glaucoma situation, keratoconus situation, stage 2 by pentacam. So I have to mention that I live in a city 13,000 feet above sea level, and the keratoconus is very frequently. So most of the population in La Paz, Bolivia, they have keratoconus. So the problem was first resolve the macular trauma. So there's a phaco-vitrectomy. So right now we are removing all the tractional membranes from the macula, horizontal and vertical. And at the end, we are going to perform a small shape around the choroidal rupture. Okay, we use SF6 intraocular gas at the end of the procedure. So those are the post-op picture from an anterior segment and the post-op pictures of the angiography before and after. And so as you can see, the striated appearance remains of the neuroretina. And 3 months later, we performed a combined corneal technique, PRK plus cross-linking. Because we need, we believe that the visual acuity could improve more. At the moment was 2100. And after the procedure, we got 2070. So we know that this type of patient got also the visual distortion, and it kind of improved considerably. We are making all the follow-ups for avoid subretinal neovascularization because of the trauma. But right now, this patient is okay, quite okay. Thank you.
Thank you, Dr. Marcelo. Dr. Natarajan, would you like to comment on this one?
I think excellent surgery, but I think it was quite a tough surgery because the membranes were close to the macular hole, and I think he got a modest visual improvement following a surgery like this. I think the lesson is, I think, however bad the visual prognosis, I think as a vitreoretinal surgeon, we have to attempt like Marcelo.
Yes, and well, as you know, of the subretinal neovascularization still is the main problem right now.
Thank you. And Dr. ANDRÉ JUCÁ, do you want to comment on this?
Congratulations on your surgery. How old was the patient? Excuse me.
19.
19 years old. Yeah. Yeah, it's nice. Well, it was kind of. I didn't see you removing the posterior hyaloid was already detached in this patient.
You know, when it comes to trauma and this type of fibrinosolar membranes, it's also one tissue, you know, and you need to remove it all. And there's, I mean, I couldn't remove also the ILM because we were really, really attached because of the trauma. So I prefer to stay still.
Yeah, very nice surgery. Yeah.
Thank you.
Marcelo, very nice surgery. I have a question. The lens status had an opacity or was translucent?
No, it was a cataract, a traumatic cataract, yes.
Okay, sorry, okay. If the lens status was translucent, would you consider perform the cataract surgery after, like, and try to implant an toric IOL?
Well, I prefer to do the cataract surgery after the macular surgery. No, I mean, sometimes a patient got a good visual acuity and you don't need to remove it at all, or the lens. So that's, but in this situation, the patient got a cataract, traumatic.
Okay.
Just a comment here. The patient is 19 years old and had keratoconus, so the lens choice is just, you have to choose between lenses without toric consideration here, because you had a cross-linking, didn't you, Marcelo?
Yes, I mean, yes, we performed the combined surgery at the same time. You know, the measure of the lens was performed by the corneal service using I can't remember right now the lens calculation, but they usually, as you can see, the post-op of surgery, the lens, I mean, what it was the visual acuity and the refraction was like 0. So that's part of the anterior segment service in my institution. Yes.
Yeah. Very, very beautiful case. Now we will proceed with Dr. Natarajan. Do you have your case? Can you share with us?
I will do that. Thank you, Hudson and all the friends. 1 second. You can see my screen now?
Yeah, perfect.
Yeah, perfect.
So I have again a trauma case from a post-road traffic accident with a closed funnel RD and like a suprachoroidal hemorrhage. And the patient had an injury after the road traffic accident. We was referred to another hospital, did the corneal wound repair apart from his bodily injury. And then about 3 weeks later, when there was a vitreous hemorrhage with a total retinal detachment, the suprachoroidal hemorrhage, they said it's almost inoperable, but in case you want to try, you try to go to Natarajan, and that's why they came to me. And this is a 34-year-old male presented with closed funnel retinal detachment with suprachoroidal hemorrhage following a road traffic accident, and then an initial repair done almost a month earlier. So I planned a bimanual vitrectomy with the perfluorocarbon liquid, also using the chandelier illumination. So here I'm using a AC entry and watch the IC now. And you can see the entire retina is like totally like a funnel shape going from, it's like the whole retina is cropped up, and then the giant tear from the temporal side had been adherent to the nasal retina, I think because of the perforating injury. And I think that's why I use the chandelier illumination, and then started using 2 forceps to open up the fold. So you can see I removed the subretinal membrane, and then I'm trying to unfold the retina. And I separated the fold and then used the PFCL and remove the retina totally. And I'm using the retina using the brush to remove the folds. And I did a 360 degree, it was almost like a 350 degree retinal gap. I smeared on that 10 degree retinal also, and then did a, you can see some amount of in the extreme periphery, which I left it like that, and used silicone oil as a dampener. I did a PFCL silicone oil exchange, and you can see this is how the corneal tear was, and then extremely, there's no iris left also. I think the primary injury, it was expelled. So this was the post-op picture. You can see the pre-op corneal tear with the hyphema, and then we did the, you can see the post-op, still the corneal sutures in situ, and this is a fundus picture showing the attached retina. And only thing is this patient developed recurrent PVR 3 months later. So I did another surgery and used the Denziron, and then I had to remove it. It's about 3 months now. The intraocular pressure is maintaining. And so this is what I did in this case.
Thank you, Dr. Natarajan. It was very challenging case. Dr. WAICHING, do you want to comment on this one?
Sure. Yeah, this definitely a very challenging case for any trauma, and I think that Dr. Natarajan have done a very good job for the managements there. I guess you must have skipped the part for draining the suprachoroidal hemorrhages, because I saw in the presentations that the patient has suprachoroidal hemorrhages and a fundal detachment. And yeah, so usually the suprachoroidal hemorrhage need to be drained first to allow you to have working space, and looks like the drainage is very complete. For the closed fundal detachment, any special techniques that you use to open it besides using a bimanual method? Because some people prefer to use like viscoelastic to try to open it up so that it, because using the heavy fluid, sometimes they run out and they don't stay inside the funnel to open it up properly. So what is your preferred technique?
I think you're right. I think most of the time PFCL goes off and you can't do. So that's why here I use the chandelier illumination and use the 2 forceps to separate the fold, because it was actually adherent from disc to almost the periphery because of the, it took 1 month for the patient to come to me. So I think I separated and found a little gap. I could see the disc through that small, it's like a funnel, small opening. So I could go up to the optic disc and inject the PFCL, and then it opened up. But I think several cases, as you rightly said, it actually overflows, and then the retina, the PFCL is over the folded retina. So in those cases, I use the viscoelastic, have a space for optic disc and macula to open, and then use the PFCL.
Yeah, no, the patient did very well, and you've done an excellent job to reconstruct the retina and reattach it. Very good.
I think I had one patient, I remember, I don't know why, I could do under the PFCL. Then I thought I'll remove the PFCL and do a oil separately as fluid air exchange and oil. And I think that again, it got folded up. And that particular case, I remember about 15 years back, I could never open it up. I don't know why. It just got like a small flower closed and it never opened. So from that time, I make sure if I open the funnel with the PFCL and I use the PFCL oil exchange so that there's no thing happening. That's why I think all the laser, everything I do under the PFCL, then do the PFCL oil exchange.
For the drainage of the suprachoroidal hemorrhage, your preference, because there are different techniques. One is that you can just do a cut down externally through the scura, and people also use the cannula for the vitrectomy cannula to drain them. And do you have a preference?
So I nowadays from the 23 gauge available, I use the 23 gauge cannula depending on the ultrasound where the suprachoroidal and go posterior to the as much as possible. And in the I do put the trocar cannula and do not put it through and through. So halfway through it will be there so that when you have the infusion line through the AC, you have the intraocular pressure little up and you can squeeze it out and all the suprachoroidal hemorrhage comes out.
Great.
And I think
Thank
for a
you.
long time I'm not done sclerotomy. The earlier time I was doing open the conjunctiva and tag the muscle and do a sclerotomy. But now I think you can put multiple trocars and maybe more than 2 or 3 also posteriorly, depending on where the amount you have.
Yeah, I guess the nowadays we use the valve trocar a lot of time, valve cannula a lot of time. So in order to drain it, I guess you have to use the those either defeat the valve or put in the drain so that the blood can escape through the cannula. Because the valve cannula will make it difficult to drain otherwise.
I think valve cannula is the problem. So I use a 23 gauge without valve and also make sure by ultrasound that the suprachoroidal hemorrhage is liquefied so that it drains easily. So you wait approximately 10 to 15 days.
So this particular case, YOSHIHIRO, there's one other option to drain the suprachoroidal blood, and it's an internal. Because, you know, he had a closed funnel RD. Most of the time we wouldn't even consider that because we got retina to go through, right? We don't want to create a retinal break to drain a choroidal.
Yeah.
But in this particular case, right, where you saw that first view of a closed funnel RD there, you know, I presume that was probably caught somewhere at the wound and you cut that off. And then once that was then separated centrally, if the choroidal was there, you could have drained internally, go right through with the cutter. And sometimes where that can be very effective is if there's clots still. So if you're trying to drain externally and it's not draining on you fully and it's not all liquefied and there's clots in there, you can put the cutter into the suprachoroidal space internally in a case like this. I'm not advocating that on every case at all, but this was a unique picture he showed us at the beginning of that surgery.
So I think it's a great, I think it's a good, I've never done that. And I think it didn't strike me that you have a pair choroid everywhere. And probably, I think it's a good lesson I learned.
Thank you. Dr. André JUCÁ, do you have a case for us?
Yeah, sure. Okay. Okay. Okay.
Case?
This is the first case that I'm going to present is a giant macular hole in case of a young patient, a 14-year-old patient with Alport syndrome. So this was the first case that we did. The patient has this anterior lenticornis. He had also hearing loss and some kidney issues. We decided to remove the lens because of the lenticonus. It was more of aqueous. And then we have this really giant macular hole that we're faced of. Do you have any ideas to how to treat this? Anyone want to comment on that?
I would definitely put something inside, you know, the ILM at least. Okay.
Yeah. Okay. Let's move on. This, you know, is not like our regular macular holes. The edges, they are very floppy. So we are going to see here a little of the OCT. And then of the surgery, we have really a bad time removing the posterior hyaloid that was very adherent. We try everything, but it was really hard to remove it. And at some point, we got to remove the hyaloid, and we think also the internal limitant membrane. And we caused some major retina issues, some breaks, and we fixed that as well. Well, as you see, it was really very hard to remove the hyaloid, but we managed to do that. And we decided, since it was a very big hole, to put some amniotic membrane inside, and it fit quite well. The amniotic membrane was not that hard to put on. In big holes, I guess it's easier than in smaller ones. So we did this is the breaks that we cause when we try to remove the posterior hyaloid. We made a fluorescent, and we did get the macular hole closed, and the visual acuity improved slightly after the surgery. We are still following the patient. He has some macular atrophy on the other eye, and this one maybe is going to be his best eye. This was my first case in this issue, and I don't know if anyone has experience in this giant macular hole in Alport syndrome. Anyone want to comment on that?
Sure, I think what you did is pretty darn reasonable. I mean, I think you're looking at that and autologous retinal transplantation are probably the two most popular choices for a massive hole like that, right? So, you know, I think the interesting thing about the technique I saw you, that was a big piece of amniotic membrane. I'm not sure I've ever seen anyone put such a big piece under that, and it worked beautifully, right?
Yeah. Yeah, I did. It was like 1 millimeter. It just fit the hole.
Yeah, it just fit the hole.
Yeah.
Okay. And you didn't use viscoelastic or anything to lift up the edges of the hole. It was already up for you.
The hole was, like I said, it was very floppy. So
it was easy to get under.
Yeah, it was very easy and was very big. So this is the technique of putting in a big hole something inside is easier than in a small one.
So there was a Zoom session I was on a couple of weeks ago, and I forgot the surgeon's name, but he's at Kresge Eye Institute in Detroit. And what he's doing is he's taking the amniotic membrane and he's splitting it in half because he didn't like how the OCTs look postoperatively with a full amniotic membrane. So he's peeling the stroma off of the basement membrane, and then he's just inserting the half of it in there. And he showed some beautiful post-op OCTs where the tissue that he had put in there dissolved much more quickly than the typical amniotic membrane.
Yeah, that's true. I saw that video too. But you know, maybe it's a good idea. You see this thick band here is the amniotic membrane. You see?
Yeah. And that's how long post-op?
This is just like 2 months post-op.
Yeah.
It's not that long.
Andre, I think there's a question for you from the audience. Have you noticed any difference in visual outcome between closing the hole with ILM versus a harvested small piece of retina?
Yeah, the patient told me that he improved vision, and he did improve some vision. He was like 2400, and now he's like 2200. It's small increase, but you know, the other eye, it's in bad shape, and it's not a macular hole, it's just macular atrophy. And then we could do anything for the eye. We are thinking about doing just the cataract, I mean, the lenticon surgery.
Thank you.
So let's move to the next case. Okay. Skip. Okay. Let's move for the next case. The next case is more common. It's a case of a stick oil. We are just removing the silicone oil from a patient with giant retina detachment, and in the end, you have this stick oil and over the macula. What do you do to remove that usually?
Dr. Natarajan, want to comment on this one?
Yeah, I have not seen something like this before, but I think if it is like this, what oil did you use? What is the oil?
We use 1000 cent stoke silicone oil. We did use perfluorocarbon during the surgery. So,
okay, so I use a 23 gauge, the flute needle tip with the extrusion, and I'll try to remove the oil from the extrusion needle instead of using the viscous fluid extractor.
We did just that you told. We try to aspirate it. It comes a little bit, but not most of it. So any other ideas?
I think very good. Other thing is probably you can use viscoelastic between the silicone oil and the retina so that it may move.
Viscoelastic, we did not try viscoelastic, but we did try perfluorocarbon liquid.
It may not push. I think perfluorocarbon liquid may.
Well, it really didn't match. Right. Anything else besides the viscoelastic? We didn't try that. We didn't thought about that. But the idea is very sticky, you know. It's over the macula, so the macula looks nice. Any idea?
André, did you double check if had any vitreous with triamcinolone or something like this? Yeah.
Yeah, there is no vitreous. It's a giant macular hole and straightforward case. It seems nice. And
Dr. Jorge Sahr is suggesting Tenno diamond dust scraper.
Okay.
Yeah, I just saw that. And the other thing just coming to my mind is whether you can stain the ILM and then remove it and see whether if it's stuck to the ILM.
We did exactly that. That's we just thought that, and excuse me, I will try to come back to the video. We did just that.
Okay.
We just did the pure. And of course, you have to begin the peel away from the silicone oil drop, otherwise you cannot get under. So just go away from the silicone oil drop, and then you get you get it. There is some resistance of it's really sticky. But of course, if you remove the internal limitant membrane, then you will remove the silicone oil. And of course, it did not stain a lot, and because the oil prevents it. You see there is oil on the limitant membrane. You see how shiny this limitant membrane is. Okay, that's it.
And there's one more F6H8 the Goider company used to make for dissolving the silicone oil and removing. So for the emulsification of oil, they have done that F6H8. I forgot the full name from Goider.
Did you ever use it?
I've used it in only one, because I just bought one bottle, I think 10 years back from Germany, and I used it in one case. And it worked well. It makes a good solution between the PFCl and oil, particularly when you have a emulsified oil.
Yeah, I think it was some perfluorocarbon that's mixed with the silicone oil. I have never got this. That's first time, and it was just over the macula.
Yeah, good. I think you stimulated our thinking, and we probably did the same what you did. Good. I think you should publish this.
Yeah. Okay. Okay, that's
Thank
it.
you.
Thank you. Thank you very much, my friend Nakaji.
Thank you
Yes.
very much, Dr. André. And now, Gustavo, do you have a case for us? Can you share a screen?
Yes, my
And
friend.
André, can you just quick? Yeah, thank you.
Okay, let me just share my screen here. Let me see here. So first of all, good evening, good morning, good afternoon, everyone. Thanks, Hudson, for inviting me, and congratulations for all the nice talk so far. So let's start. So this case is one of my first trauma cases many years ago. As you can see, I had to use iris hooks. The retina is totally detached, and I can work very much just with low vacuum. So one of the things that I have learned when you have cases like this, inject PFO, and you're gonna see the subretinal fluid coming up. I would have saved lots of time and coronaries after doing that. Look, I have more space now. Actually, I should have injected more PFO because here I do a small hole at the retina while doing the vitrectomy. And after I have done it, I also have a choroidal detachment. So controlling the pressure is very important in such cases, okay? Here I'm lasering already at the end. I could reattach the retina totally. And at the end, I take the hooks out, and I have to suture where the foreign body had cut the eye, but it didn't enter the eye. I do an inferior iridectomy. I suture where the lesion was done, and at the end, I inject silicone oil, 5,000 centistocks. That's it, my friends. Thank you.
Thank you, Dr. Gustavo. First of all, I wanted to say that Gustavo is an enthusiast in movies and is an enthusiast in recording surgeries, and have more of these kind of things to share with us. In the next case, you can bring it to us.
Thank you. No, thank you, my friend.
Dr. Vasco, do you want to comment on this one?
Sorry. Very nice case, Gustavo. Those trauma cases are very challenging. I'd like to know if you have any preference of type of oil on those cases, or you use 5,000 oils, 1,000 oil. Do you do any preference? Do you have any different types of surgery that you choose one type or other?
That's a very good question, Vasco. Thank you. Many years ago, I published an article in the Retina Today magazine discussing that. And for me nowadays, one of the main factors deciding which type of silicone oil I'm going to use is the socioeconomics of the patient. Okay, if it is a patient who lives very far, because I'm in an area where I'm the only VR surgeon for more than 1 million people, and most of them live in the rural area. I'm gonna put 5,000 because sometimes these guys don't come even for the first week revision, okay? And if I see it is a person who is going to fall, who I will be able to follow up, then I use 1,000, and especially if I see that I will be able to remove the oil. In cases where I see that the patient is not able to take care of himself, then I prefer to use 5,000 and many times to leave it. And I just control the IOP.
On those cases, for when you remove the oil, do you usually change your approach about the liquid that you use in the vitrectomy system? I've heard some theories that you could use ringer instead of BSS when you remove silicone oil due to the potassium and all the ions change that you have during the removal of the silicone oil. Do you have any different approach, or you remove with regular BSS?
Actually, I have already used both because I have read the same thing as you, but here in my practice, I didn't see much difference in the silicone oil removal time.
Very good case, Gustavo. I think I also will do the same. And many times if I use 1000 and I have to remove it, then if you have to keep the oil for longer, then I use 5000. And I think you have to follow up the patient, one for the corneal changes happening with the long-standing silicone oil, even with 5000, even though it's supposed to be lesser. And sometimes I thought Denziron heavy oil will be below and cornea will not be affected, but I was wrong. So you still get corneal changes even if you leave it longer. And the other problem is with the heavy oil is disc will get paler, even if the pressure is not high. So I think we have to use that as a short-term tamponade and 5000 as a long-term tamponade.
That's true, Natarajan. Thank you for your comment. And the corneal changes is a big issue for me because actually, first of it, I always do inferior iridectomy, but sometimes you have patients which are using oil for a long time and you don't see any corneal change. And many of them in the first months, they already do have it. So maybe it's some systemic issue or a prior damage corneal endothelium. I didn't see yet a pattern for that.
Gustavo, yes. I have a question, please. Do you
Yes.
have experience with the transconjunctival drain of the choroidal?
Sorry, again, it cut.
Do you have experience with the transconjunctival drain of the choroidal? I mean, using the trocar.
Yes, I've used it sometimes, especially when I have my trocar under the retina or it's too angled and it doesn't enter the vitreous cavity. I've used it sometimes and it works, but I still prefer the old way to cut the sclera and make the blood drainage.
I think that's what 23 gauge cannula works very well.
Actually, here in my practice, I just have 23, so I always use 23. And another thing I wanted to point before when Dr. CHOW talked about 27, I think the biggest issue here is because most people already have all the instruments in 23 or 25, and changing all that is very costly.
Yeah, right. Thank you very much, Gustavo.
Thank you.
Now we are just finishing with Hudson. He has a case for us.
Yeah, I have a very nice case. And last but not least on our list, I will counteract all expectations. I've done a lot of MAC hole surgeries, and I usually, in the past, we used to do a normal regular ILMPO, and that was about it. And it worked okay. And when we see the large macular holes, what would we do? You know, I tend to do ILM stuffing in, ILM inverted flap, but this case is going to counteract all my expectations, or maybe anybody's expectations. And I'll try to share it now. Just a second. It was actually this case had this large macular hole, but I just did the regular way. So let's go. This is the iBank Foundation. And we have this case, large macular hole, almost 800 microns. And we've been following this case, and we decided to do this regular vitrectomy with brilliant blue. And that was so cool surgery with no trauma. And so after removing the ILM, I thought, should I put it inside the hole or not? I just decided to leave it like that. And so this patient has been followed since 2016. And the hole closed, and it's still closed. This is a laser, prophylactic laser. And you follow here 16 and 18, the hole is closed. And we did OCT the hole is closed 4 years later. So I just did the regular way. I tried to do, I thought doing something different. The other eye has had the vitreomacular tract syndrome, and he was treated with regular surgery with only, I actually, for the other eye, I did ILMPO, and I counteracted the vitreomacular tract syndrome from the other eye, and that was about it, just following the other eye. And this eye, because the macular hole was so large, and I could have thought of doing something. So and I've done plenty of surgeries inserting the ILM inside the hole, and they worked as well. And I've been doing many surgeries with silicone oil and peeling the retinal detachment and then peeling the ILM under PFC, and it worked good as well, but some failed. But this case, we taking into account, should we really do ILM stuffing in or inverted flap for all cases, you know, because this is a large macular hole and then it closed briefly.
Dr. WAICHING, do you want to comment on this one?
I think, Hudson, you raise a very good questions. I think all macular hole are not the same. I think the technique depends on the size of the hole, the presence and absence of vitreous attachment still there, and the chronicity of the hole. All those should be taken into account. I think those complicated technique necessary for the large chronic hole, because the closure of those holes with just peeling IOM with a vitrectomy probably will not be sufficient. But for a small hole with the presence of posterior vitreous detachment, then I don't think you need to do the IOM flap or all those extra procedure, and the closure rate is quite good, and we have shown that in the past before all these new kind of approaches or these different approaches that's been used. So I think I don't think this is one size fits all kind of approach to macular hole. You have to kind of make that assessment. In the case that you have, there's a lot of cystic changes at the edges of the macular hole. The hole are not overly large, and that could very well explain the reason why the hole closed with just the IOM peel and the vitrectomy and gas.
Hudson.
Yeah, that's right. And we had this hole for quite a while, and we did not take too long to operate. But the thing is that the main diameter was almost 800 microns. So I was thinking, should I, because I'm familiar with the ILM inserting the stuff technique and the inverted flap, but I decided not to do it, and it worked perfect. And as you said, you've got some cystic changes there, and the edges seem to be approaching, so that helped it a lot. Yeah? What do you think, Dr. Yoshihiro?
Yeah, I think that was very beautiful, normal surgery, and I think it was clearly the right choice. I think looking at the OCT is really important, and the one thing that this patient had going for this patient was that the hyaloid was still attached to the optic disc, and with a complete PVD with the hyaloid off the disc also, I think that's a very bad prognostic indicator where you might want to consider ILM techniques. But here, it wasn't the worst case scenario. That being said, if you do 100 of these cases, you'll have more that will close with ILM techniques, I'm sure. One thing that I just wanted to mention, stuffing ILM into the hole is probably not ideal, but placing it on top of the hole as a hinged flap, I don't think affects any poorly on visual outcomes. So if you get a free flap and really stuff it in the hole, you look at the OCT afterwards and you have that gliotic tissue that compromises visual outcomes. But if you keep it hinged on the edge of the hole and just flap it over so that's sitting on top, those patients do really well. And personally, I don't think you're compromising visual outcomes. And that's a nice way to kind of start as the initial technique for these kind of holes personally.
Thanks. And how do you get away with the air fluid exchange without dislodging the eye element flap?
Yeah, great question. So the hinged flap is nice because it's usually hinged. I put a little viscoat on top usually as well, and I do the air fluid exchange very slowly in the direction that the flap is hinged towards. I keep the eye tilted in that direction.
Yeah, it was tough to decide, not doing. It was attempting to do the thing, and but that worked well. And this eye is pretty good vision, 220, 100. So it's not that bad. And the hole was large enough. And the other eye had this vitreomacular traction syndrome. I was following for 4 years, and he disappeared for a while after the first surgery. He was happy with the surgery from the right eye. So he showed up 2 years later with the traction way over the macular area in the left eye, and we did surgery, and the other eye is 20/60, which is not that much better because he got some cataract, and he's gonna proceed cataract surgery, and this is a good case, and ended well.
Okay, thank you very much, Hudson. Does anyone has any comment on this, or in another case, do you want to say before ending this session? No? So we must end the session. Thank you very much for these cases. Congratulations. Every case was challenging and added something new for our practice. Thank you very much.
Thank you all.
Thank you.
Bye. Thank you.
Great.
Good to
Congratulations, Hudson.
Nice. Thank you,
for doing
Hudson.
this.
Bye-bye, Hudson. Thank you very much.
Thanks, Hudson. That was great.
Thank you.
Thank you very much.
Yeah,
See you
Hudson.
next time.
Bye.
Bye-bye. Bye-bye, Castellanos.
Bye-bye.
Thank you, Hudson. Wonderful. Wonderful, Hudson.
Thank you very much, Rafael, for the moderation. You are awesome.
Thank you very much.
WAICHING, Natarajan, hope to see you in Thessaloniki very soon again, okay?
Yeah, yes.
so.
Look forward to it.
And this is a COVID year.
Yeah. Hudson, congratulations. 10 over 10. Really, really good. Very high quality
I
content.
learned a lot, this audience here, this panel, I'm very proud of having you, and I'm learning every day, we learn with the surgery.
We all do it. Congratulations. Keep the good work. Bye-bye. Good evening.
Yeah.
Good night.
Congratulations, Hudson. Also, well done for a second retinal. And the kinks from the first time is gone. It runs very smoothly this time.
Yeah, that's it. I had some freezing here, but I think it's the internet, but it was great. It was much better than the last time.
Yeah,
And last but not least, congratulations to Rafael, our moderator. He was really good. He is a professional. Congrats, Rafael.
Thank you. You're all learning.
Bye-bye.
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 Bye-bye.